Hi, Dr. Gavin. We can start now. I would just first would like you to to give a brief about you for the attendance.
Sure. Thanks very much, Mohammed. It's a real pleasure to be taking part in this Hope Special talk series, especially with you, because dealing with complex problems in children with cerebral palsy is a team game. There is no doubt about it. The days of single-handed practice are gone. It is much easier as a team, and I mean this most genuinely. It's a real pleasure to have you on board. Without your input, I feel like I'm trying to do this with my hands tied behind my back. Because I'm just a simple orthopedic surgeon. I'm a bonesmith. Those are the only tools I have in the box. As you can hear in my accent, I'm UK trained. I'm a Londoner, and I've been doing pediatric orthopedic surgery as a consultant for about the last 15 years. I very rarely treat adults. I find adults difficult as patients, if I'm totally honest. I'm much happier with children as my patients. And as a pediatric orthopedic surgeon, you have to turn your hand to a number of things, but I have a particular interest in cerebral palsy. I find it a fascinating condition, real challenging to work out what is the best way forward, and I really enjoy the teamwork. So that's me. I'm permanently in Dubai now, and it's my pleasure to have a clinic at Hope AMC down in Jumeirah with you and other colleagues who we work with. We've got a good team going down there, I think. Would you agree?
Sure. We're actually happy to have you on board. Yes, I believe in teamwork, especially when it comes to cerebral palsy, where we have to tackle lots of aspects of children need. I've been a pediatric physiotherapist, treating only pediatrics, most of it also with cerebral palsy, since 2012. I have had my master's degree with research also all dedicated to cerebral palsy and using different approaches. My best approach and the big framework that I adopt is the International Classification of Function and how it focuses on what the children really do in their daily life, and not just try to make everything perfect or fix all the impairments. So let's start with our topic today. As Botox is one of the methods that we control spasticity, I would like you, doctor, to give the audience an idea about spasticity and how Botox helps to control.
Sure. Yeah. Botox is a really interesting and popular choice for treating cerebral palsy, but it is by no means the answer to cerebral palsy. It is, perhaps I should explain, it's a medication, it's a drug, it's designed based on a biological toxin from botulism. It's a powerful form of food poisoning. So this is what botulinum toxin is. That's what Botox is. It's a bacterial product. Well, originally was a bacterial product, and it has the very useful property of being able to block transmission between the end of the nerve and the muscle. So that might be useful if your muscles are very overactive, which is, I suppose, one definition of spasticity. So spasticity, people have whole conferences about what spasticity is. But I think to most clinicians, what we mean is a muscle which, when you stretch it, has a habit of contracting, having an exaggerated contractive response to being stretched. And this is a natural phenomenon. All of us would do it. The reason I don't do it is because my cerebral cortex is sending down messages to say, calm down, control these reflexes. So children with cerebral palsy can, not all, but some, a lot, have problems calming down those reflexes, such that when you stretch muscles, they have a habit of contracting in response. And there is no doubt that Botox is a powerful way of temporarily controlling that, dampening it down. So it's given by injection. There's no other way to give it. You can't take it in tablet form. It lasts for a few months before its effects wear off, though we may get into what the long-term effects might be. So it's reversible, which in some ways is good and in some ways is not so good. But I think the real issue with Botox is understanding that spasticity is not the whole challenge with cerebral palsy. I mean, that's my major, that's one of the myths I would like to bust about it. Would you agree with that?
Yes, definitely, because cerebral palsy originates from an insult to the central nervous system. So there's many results that this insult causes. Only one of them is spasticity. There are lots of other phenomena, the biggest of which is muscle weakness, problems with coordination. So fixing spasticity or controlling the spasticity will not control the whole clinical picture. So the way we get to recommend such an intervention starts way earlier, before we decide to, okay, go for injection. It starts with, okay, we first need to talk to parents, or the adolescent, if he's or she old enough and comprehensive and can set what he or she needs. Okay, what are you looking for? What function are you looking to achieve? And then with our clinical assessment, we also give them an impression in a very objective way, at which level, at which functional level is the child or the adolescent at. And based on the clinical assessment of the function and the functional target that the parents and or the child or the adolescent are looking for, we then prioritize one goal and we analyze what is first, is it possible? And what are the barriers to achieve such a goal? There might be some weakness, it might be we need an assistive device, it might be he needs training, it might be there is tone in a specific muscle that if we can reduce it and then train it hard enough during this temporary period of activity of the injection, would help to achieve such a function. So recommending Botox needs a thorough assessment for primarily the function that the parents and the family are looking for, and then what are the underlying causes. And if spasticity is one big barrier to achieve such a function, that's when, okay, one of the team would recommend it, and then of course will not take the decision on himself by himself, but we need to refer back, okay, Dr. Gavin, what do you think about it? Then we talk to the OT if it's an upper limb function. What do you think? Would tackling this specific muscle help? Or we can also talk to the neurosurgeon. What do you think? And so on. So then everyone puts their clinical judgment, and then the decision comes on. And of course, during this temporary period of time, it's good that it's temporary, because later on it's reversible if the result was not as much as we wanted. So the effect is mostly reversible. But the good thing during this period of time, I call it the window to strengthen the muscles that counteract the muscle that has the tone, and to let the child gain this active control, this new plans, this new synapses in the brain, that when the tone comes back, it won't come back and find nothing. It will find an active control that can resist it and help the child to keep the active control. So this is the only way that we can control tone.
Sure.
Yeah.
I mean, I'm glad you mentioned weakness and control, because what some people talk about with cerebral palsy, they talk about the positive features and the negative features. By positive, we don't mean good. We mean something that children with cerebral palsy have that normally developing people don't have. Spasticity is a good example. So it's very obvious, and a lot of people focus on it and think, well, if I can just get rid of that, everything will be a lot better. But the negative side, the negative aspects of cerebral palsy are those things that children with cerebral palsy lack. They are less obvious, but in many ways they are more important. And the two that you've mentioned there is, number one, weakness. We know children with cerebral palsy have small muscles. They are weak. Getting rid of muscle tone is not going to address that problem, though it may, as you say, it may allow you to do a targeted form of strengthening, which can help. So Botox can be useful as an adjunct to other types of treatment, for example, strength training. And the other thing you mentioned was coordination. So if we talk about children with cerebral palsy who can walk, you and I walk without even thinking about it, but actually you're firing muscles all the time, all the way through the gait cycle in a very specific way. And children with cerebral palsy have challenges with that. They often fire muscles at the wrong time. Again, dealing with spasticity is not going to solve that problem. So it's a complicated picture. I think you mentioned about tone. I mean, another thing that people ask about a lot is selective dorsal rhizotomy, SDR. I suppose tackles the same problem, but permanently through a neurosurgical procedure. But they have the same concerns. It's not going to cure the problem because you still have weakness and you have muscle coordination problems as well, right?
Yeah, and some at some instances, the neurosurgeons use Botox as a trial to see if SDR would be a good solution. To mask the tone for some time to see how strong the muscles are. Are they enough to keep the child active and functional if they did the selective dorsal rhizotomy or not? And of course, who else comes into the picture with injection is the orthosis, the splints, and how to tune the splint or the AFO or whichever piece of orthosis to get a benefit of the new range that we gained after injection. And I would like also you, Dr. Gavin, to pinpoint the importance of casting at many instances.
Yeah, so one of the other features of cerebral palsy is the development of contracture. So Botox can be useful in combination with serial casting, which means putting a cast on a limb segment and then changing it, usually every week. Sometimes it can be quicker than that, to gradually overcome that contracture. So two things about that. One, the evidence suggests that may be easier to do if you give a dose of Botox some weeks before, usually about 4 weeks before, because that's when the effects of Botox are most apparent. So it allows you to gain more correction from this process of what we call serial casting. Serial casting, though, it only works for relatively small contractures. Evidence would suggest around about 20 degrees. If you've got more than that, probably serial casting is not going to help very much. And the other problem is that if you have a dose of Botox and then somebody puts a cast on you, boy, you are really provoking the weakness that is already underneath it. So you're going to make sure that after the casting is done and the Botox is given, that we have a proper strengthening program in place to get this result. And this is why the teamwork is so important. You cannot do this on your own.
Yeah, of course, because if you just got the injection and the casting and you just stayed home without training on the new function that you're looking for, then you didn't get the benefit of the injection in the first place. And that's when I want to, again, bring back everyone to the functional level. I would like all parents who have children with cerebral palsy to know where are their children, at which functional level, and there's a universal, very standardized system that we can classify children with CP. It's called the Gross Motor Function Classification Scale. It's very easy to understand. It's parent friendly, and it classifies cerebral palsy children with cerebral palsy into 5 levels. I will share now just my screen to show everyone some illustrations that can 1 second. Okay. I'm able to share.
Just while Mohammed is sharing, a message to everybody participating, please type your questions in the chat box. This is going to be much better if it's interactive. Otherwise, we're just going to we could talk all day about this. So you don't want that. Probably better that you type some questions.
So if everyone Googled Can Child, it's one of the biggest institutes for research about cerebral palsy. They have developed this scale that's called the GMFCS. And this is an example for the children between 6 and 12, because it gives different classification to different age bands. Before 2 years, between 2 and 4, between 4 and 6, 6 to 12, and 12 to 18. So we'll give an example for children between 6 and 12. For example, level 1 are completely independent walking children, and they can also climb upstairs without holding rails and so on. They have just some challenges with speed and balance, but they are still independent without assistive devices. When it comes to level 2, they are still independent, but the speed and coordination are more limited. And in unusual conditions like uneven roads, inclines, slopes, they are not very confident with walking. And when it comes to stairs, they usually need 1 or 2 rails to negotiate steps. Level 3, they use alternatively walking aids and wheelchairs, because they usually have challenges walking long distances. So if it's a short distance indoor, or a transfer from the door to the car, or within school, they are able to use assistive devices like walkers or bilateral crutches. But when it comes to long distances, they need wheelchairs for efficiency and more functionality. And then level 4 and 5, they are most of the time in postural support equipment, because they still need support for the trunk, support for the head, support for the arms. Just a distinction between 4 and 5, that 4 can still walk in a body support walker with other supervision. And and they can also achieve powered mobility using an electric wheelchair or something like that. So this is just a brief about the system. There are more details into it. Again, it's parent friendly. You can just read some details and know at which level is your child. And this would definitely guide you. What is the next function that I can achieve? For example, if I'm at level 3, then I will not look to achieve walking hands-free. So this is a very big jump that might not be achievable. So I have first to look at level 3. Is my child able to do all the skills that level 3 encompass or not? So let's fulfill independence first. Independence is what we need to seek, not just walking, but independence makes more sense. And how to achieve such independence? Is Botox just the only way to achieve it, or we need to plan much more? We need first to see what is the function that we need, how do we get to it, and what are all the ways. And then if spasticity is the only barrier or the biggest barrier to achieve such a function, this is when we ask, okay, is Botox the right thing for me or not? Because as Dr. Gavin mentioned in the beginning, not all children with cerebral palsy have spasticity. There are different types. So Botox will not be beneficial with all types of cerebral palsy. So this is where professionals make the decisions. Yeah.
I'm really glad you mentioned the GMFCS level. It is key. It is so key, and it's always surprising to me here in Dubai. So many people don't seem to have heard of it. And as you say, if you go on the CanChild website, you can classify that. There's a section there for a questionnaire for parents. You can classify very easily your child yourself, and it's in various different languages, including Arabic. And a key point is if you are GMFCS level 2, you will remain GMFCS level 2. You cannot jump and become a 1, nor are you going to deteriorate and become a 5. That's how you're going to be. And this is really useful because it allows us to predict with accuracy what function your child is capable of. There's no mystery about it. Sometimes it seems to me there's some confusion that people think, well, if I just do more physio, if I just have a better splint, or if I just do Botox, something miraculous will happen. That is not the case. This GMFCS level is so useful to us because it allows us to be realistic about what the goals are and to plan our treatment effectively. So yeah, I'm glad you mentioned it. It's such an important thing.
Great. We started having questions. So first question is about dystonia and Botox.
Yeah, great question. And also
Yeah.
about Botox for children with SMA. So for dystonia, for focal dystonia, yes, Botox is useful. For generalized dystonia, Botox is not useful. There are other treatments that would be more useful for that, including both drugs and medication. For Botox in children with SMA, I've not heard of it, but it kind of doesn't make sense to me, because SMA is a condition of it's essentially a lower motor neuron lesion, whereas so I don't think spasticity is a big part of it, although contracture can be. Unless differently, I don't think it plays a role in SMA.
Yeah, I haven't encountered lots of maybe we can have a look deeper in research and evidence to see if there was any trials. But yeah, weakness is quite obvious. So we in such conditions, so we would not need to provoke it anymore unless there is any. Yeah, it needs to a review to research and evidence to see if there's any trials for Botox with SMA. Another question.
Yeah.
Some kids with quadriplegia, grade 2 and 3 spasticity, they had Botox, and parents did not benefits. We recommend to get Botox again. Reported that they did not get any benefits, and they get recommendations to do it again. So yeah, limitations of Botox injection. So I think it's where the professionals did not make goals clear before the recommendations. Before I give you a recommendation of Botox, I need to give you an idea. What will you expect? What is the gain? Is it a new function or prevention of a secondary complication? At some points, for example, for GMSS level 4 and 5, where it's very common to see hip dislocation and hip subluxation, problems with the hip joint due to the asymmetrical pull or the strong pull of the tone on the hip joint. It's many conditions also causes severe pain to the kids due to this strong tone. And when pain becomes that hard, even taking care of the child and changing diapers and giving showers becomes really challenging for parents. So this, some points, is a goal, just to relieve pain or to make care easier. And some points it can be for sitting control. At some points can be for better walking patterns. So it's not always, Botox is not always used to gain a new function. It just may be used to prevent a secondary complication or just make life easier. So again, you need to get back to the team of professionals who gave you the recommendation to first ask, why am I getting this injection? What should I expect? And then you see if this goal is convincing, is enough for you, or is enough reason to get to such an intervention.
Yeah, I agree completely. It's all about the goal setting. If didn't find any benefit, well, what benefit was expected? Botox is great for certain things. As you say, for pain relief, it's good. Actually, it's also good for controlling excess drooling from salivary glands, weirdly, because of a quirk of the way, you know, those nerves transmit their signals. So it all depends what the goals were. Yeah, agree totally. We also have a question from Abe here about, is there an age band where Botox would be most beneficial? My son is 2.5 years old with diplegic CP, spasticity in both legs. He cannot walk yet. So, I mean, my first thought about that would be, let's just go back a step. You know, you talked about the GMFCS level. This is going to be really key for a boy this age who has cerebral palsy affecting both sides. We talked, didn't we? I said, you know, how useful the GMFCS level is. To know a child is diplegic, that's fine, and that's what the textbooks often talk about. If I could know only one fact about a child, imagine, you know, that my phone battery was about to run out, and I could only had time for a few seconds. I'd want to know what the GMFCS level is, because if I knew that, then I could answer this question about whether Botox might be beneficial. So I think for this young man, it's important for him to come to see somebody to be assessed and to find out what the GMFCS level is and work out some practical and realistic goals, of which Botox may be one, but may not be. That's
Yeah.
that's how I would read it. What's your thoughts, Mohammed, on this?
Yeah, of course. Yeah, it's good to know diagnosis and distribution of tone and so on. But again, we need to know the whole picture. He's not walking yet, but what is he doing? Is he sitting yet? Is he crawling? Is he creeping? Is he standing? Is he cruising? So all these functions, we need to also see what is the next function to be achieved. And then we see if Botox will help. So yes, detailed assessment with a standardized tool. We have, of course, lots of tools to assess, like the gross motor function measure, or if it's a walking child, then the gait analysis and so on,
Yeah.
to dig deeper into what are the barriers and then to decide. But
Yeah.
I don't think there is age limitation to it in terms of, because it's even used with adults with stroke. So there is no age limitation to it. It's again the condition of the muscle, the condition of the function, and all these variables.
That's right. Abe has just typed, thanks, he has level 2. So I think we're talking about a boy with GMSCF's level 2. Yet you say he cannot walk yet. So I mean, it all depends what you mean by cannot walk. I mean, you might say, well, it's obvious, but what is the quality, you know, what sort of attempts is he making? You know, the answer is that he needs a full assessment really to work out where the challenges are. For example, he have contractures already. If that's the case, Botox is probably not going to help with that unless used in combination with serial casting. So the answer is it may help, but we need to take a step back. We need to make a proper plan.
Sure.
To the next question, you were talking about the age. How frequently should the child receive Botox, and what is the time between Botox injections? And secondary question, if a child received Botox and came with worsened contracture, what does that indicate? Well, that's a great question. So here's the thing, that what we humans, we like a nice logical story. You know, we're very attracted to that. So it makes sense, doesn't it? Spasticity leads to contracture if in time. It's that. There are children who have low tone, no spasticity at all, who also develop contracture. So the link between spasticity and contracture is not as clear-cut as people might think. And there is also some published evidence that Botox and SDR actually are pretty useless at preventing contracture in the long term. So the fact that the Botox has worked to stop the contracture is no big surprise. The contracture is probably part of the natural history of this condition. It's going to happen anyway and needs to be dealt with by a separate method. What about the question about how frequently should children receive Botox? That's and the time between Botox injections. That's a really good question too.
Yeah. How many times? Usually, research varies between that. It loses efficacy with repetition. Some researchers say after fourth time, the effect is less. Some other researchers say after the sixth time. Some also researchers say that if we change the type of Botox, because Botox toxin, there's A, B, and C. So if we switch between types each time, it might give us more attempts or more times to inject. So the number is variable, but it's between 4 and 6. This is most of the researchers report. The time between injections, I think I'm not the best one. Maybe you can to answer. Yes, yeah.
I mean, usually the effects have gone after, certainly by 6 months. So should you do it again? Well, a couple of things there. One, there is increasing concern about what the effects are on muscles of repeatedly injecting Botox into them. It's a toxin, right? So it's not surprising that it has some bad effects on muscle. We know from animal studies and also from MRI studies that muscles injected with Botox tend to show changes of scarring and change from muscle fibers into fat fibers, which are obviously pretty useless for getting around. And we know already that children are weak. So the last thing you want to do is get rid of any muscle fibers they already have. Now, it might be a price that you're prepared to pay, because as we said at the start of the talk, sometimes if you can just get over that tone problem, then you can fly, in terms of it allows you to deal with the strengthening and achieve another functional. So it may be another way to look at it. It's not how frequently can I keep injecting the Botox, but did the Botox injection allow me to achieve that next functional goal? And if you've hit another functional problem that you want to overcome, then let's reconsider. Maybe Botox is the answer, maybe it's not.
But especially that during our assessments prior to Botox, we not only assess the tone, we assess the strength and what we call the selectivity. So if, for example, during the period of activity of Botox, we gained a significant number in the muscle test, in the manual muscle test, and more selectivity, then we have gained strength that can give us a good foundation for another injection. But if the muscle strength is still the same and we did not achieve the function, then why are we going to give another one? Unless, again, it's just to prevent a secondary complication, or it's for pain relief. And so again, the goal makes us take such a decision about repetition of injection or not to repeat.
Yeah, I mean,
I want to only add to the question about contractures. If we just give the injection and we don't do the prolonged stretching, then we did not fight contracture. So muscles do not elongate if you just make a 1 minute stretch. Muscles can only elongate if the stretch is sustained for 3, 4 to 6 hours, which can only happen through positioning or splinting or repetitive function. So if we just give the injection, but we did not position the muscle in a position of elongation to overcome the tightness that's developing, then we do not expect that contracture will improve, or the tightness will improve, or the range of motion will improve.
Yeah, that's a good point. The whole development of contracture is something that there's a lot we don't understand about why it happens. But we have a lot of tools in the toolbox to deal with it. Sometimes, Botox, there is a clear link between Botox injection and reducing tone. There is a much more tenuous link between Botox injection and getting better function. Sometimes we just have to try these things, right? And see, and if they don't work, if it hasn't given us the goal we want, we have to rethink, try something else. Some of it is trial and error. I think there has to be some logic to it, but sometimes we just have to see.
I think I got a question for you, Dr. Na. So tendon lengthening and tendon transfers. People are asking about, I think it's a very big question to ask, but when do you give preference to surgery than Botox and casting? And is it only the tendon lengthening, or do you also do transfers in some cases?
Yeah, of course, transfers in some cases, tendon lengthening, muscle lengthening, even operations on joints to realign them, to fuse them, operations on bones to divide and reset. When would we do these things? Actually, it's very similar to the principles we've just been talking about. Number one, what is the goal that we are trying to achieve, and whose idea is this goal? Is it the therapist's? Is it mine? Is it yours as the parent? Is it the child's? Because things are going to work a lot better if these are goals that you want, not the goals that I want. So that's the first thing. Having decided that there's a goal that we want to achieve, this is what I'm talking about, the MDT kind of thing, because surgery may be something that will help. It all depends on what the problem is. And I certainly am not going to embark on an operation without talking to somebody like Mohammed, because my bit is easy. That's all done in the operating theatre. You have the hard job of rebuilding after all of that. So it's a joint decision to go ahead with surgery.
Yeah.
So tendon lengthening, yeah. So for big contractures, Botox and serial casting is not going to work. That's where surgery can be helpful. Let's say we have a child who definitely benefits from wearing a splint. It allows her to walk better. But now the foot is so contracted you can't get it in a splint. kind of makes sense, doesn't it, that surgery is at least something we should consider to make the foot fit better in the splint, and then the function will be improved. So that'd be a good indication for surgery. But I'm going to need to talk to you guys, both you with your skills at rehabilitation and our orthotist for his skills in terms of making the splint. So as you say, yeah, it's a big question. It certainly has a role, but it's a team decision, and we have to be very clear. There is no point in embarking on any orthopedic operation unless you are very clear what the functional goal the child will get. I'm not interested in doing operations just because, you know, we're losing a range of motion. I want to know what it is that this child will gain from having gone through all of this. More questions, I think.
Yeah, sure. Yeah, what about when should we start physio after Botox? My answer would be I usually recommend 1 or 2 days after. Because some children encounter some fever afterwards for a few hours or 1 day. So once this subsides, we start physio immediately, at least to help spread within the muscle that was injected, and to start working on the goal that we wanted. So my approach is I start as soon as possible.
Yeah, I'm just wondering what the contradicting opinions were. Maybe Ahmad, you can tell us what they were. Is there thought to be any risks then of starting physiotherapy after Botox? I'm not aware of any.
To my knowledge, no. Yeah, to my knowledge, no risks to start it like next day. It actually helps the Botox to spread within the injected muscle with some techniques that we do in sessions.
Yeah. What's your experience, Mohammed, in terms of how easy it is to have a Botox injection for a young child? You know, they're generally pretty needle phobic. You know, what are the best ways to prepare kids for this kind of thing? And do you find some kids just, you know, it's impossible to do it? Maybe they need sedation.
Yeah, if the children are comprehensive, they old enough to get a dialogue, we usually let them know, okay, now we have a challenge to run. We're gonna tackle something to help you run better. So let's do something that might be not very like if you don't like going to the hospital, seeing a needle. So we're doing something that would help you to do something better. So something that he's motivated to. So the target would be the thing that we talk to them about. For the young ones, actually it comes to the parents' role now to distract them during the procedures.
Yeah, it's tricky, isn't it? That the reason I ask is because there are some interesting lessons that we learn. You know, we're children's practitioners, and we tend to think that once you get to 18, you know, that's it, problem's over. But if you ask adults with cerebral palsy what they think about the treatment they had as kids, you get some very interesting answers. The first thing is that when they're young, we obsess about walking, you know, but walking is not the most important thing. It's important, but it's not the most important thing. What do adults crave? They're the same as any other adult. They want social interaction. They want relationships. They want to be included. They want to contribute. Walking is obviously important to that, but it's not the only way. You need some sort of mobility. And the other thing is that a lot of children regret the amount of physiotherapy, interventions, stretching, splinting, operations that they had, you know, and we need to keep that in mind because their mental health is also important. And things like Botox injections and surgery, you know, these can be distressing events and need to be carefully handled.
Yeah, that's why we usually, when it comes to prescribing the dose for therapy, we need to bear in mind that this family has other aspects in life that they need to do. This child is a developing child. He needs to play. He needs to engage in sports. He has school. So whenever it comes to planning such an event, we need to choose the right time that suits the family, the right time that will not prevent the child from attending classes in school, the right time for, again, the gain that's really crucial, that push us to recommend such an event, either an injection or a surgery or whichever the procedure is. And as soon as we can transfer the child from having physiotherapy in a clinic to a sports activity that can feed into the same goal. Because again, sports has an advantage over physio that it's more motivating to the children. So whenever we can achieve a target through sports, let us do it. And usually physios are very open to talk to trainers, to talk to, okay, we would like him to work on such a muscle. And trainers are very smart on incorporating specific muscle into the training that's still fun and motivating to the child. And let the child choose which sport together with the professionals, because some sports will be suitable, some will not. Some sports will need adaptations. So it also comes the role of occupational therapy. Can we adapt the tool that the sport use, or the mobility device that he can or she can use while playing? So whenever we can transfer the child from the clinical setting to the club or to the playground setting, if of course that's what we would like it to happen as soon as we can.
That again is such a key message, isn't it? I mean, if you look at the evidence, hippotherapy, right, horse riding, therapeutic horse riding, it's really effective in building core strength, stability, and symmetry. Why would it be? Well, if you ride horses, then you'll know that you need quite a lot of core strength and stability to do it. But I think that other reason is it's fun. Kids don't enjoy doing something that's abstract and they cannot see the point in it. If a kid is motivated to do it, be it riding a horse or doing a sport, then for one thing, they're going to engage in it. For two, you as a parent are going to find it a whole lot easier because they're doing something they enjoy. And for three, you talked earlier in the conversation about new circuits in the brain, which connect up and allow you to do things, a concept called plasticity. And it kind of makes sense, doesn't it, that if you can see success and you're motivated and you like doing something, you're more likely to lay down those pathways.
Definitely, definitely.
It's
the psychological state draws the benefit from therapy. If the children are not having fun during therapy, or if they don't see the gain, because again, the children, they meant only to play. Yeah. If we're not making this in a play context as much as we can, it won't be fruitful.
Yeah.
I hope we've covered most of the questions that people are asking about Botox and clear some of the concepts that need to be that parents need to know, especially about function, about good points and side effects, and drawbacks of injections, what other things that we need to do with it, before it, other things that we can do other than it. So we're always welcome to receive your questions and to help decision making. And again, the team is the key.
Agreed. Yeah. So take home messages. I would say if you take nothing else from this, remember, one, just back up what you said, the team, and two, GMFCS level. Really important. From that, all things flow.
Okay.
So we wind up. Listen, it's been a real pleasure discussing these things with you. I'm serious. We could discuss this all day.
Sure. I can take for.
Great fun having and your expertise on it. Much appreciated, Mohammed. Thank you.
Thanks so much, Mr. Dr. Gavin. Thank you. Bye.
Right, and thanks everybody for joining us.
Thank you. For those who joined late, the meeting is recorded and it can be shared with whoever registered, so you can watch again. Thank you. Thank you, everyone. Bye.
Bye, everyone. Bye.